Hello, everybody. The title of this presentation is Implementing Hip Surveillance for Children with Cerebral Palsy, the California Experience. The previous two presentations on implementation have been quite impressive, but as I hope to show you, the challenges that we face in the US and in California are quite distinct. Here are my disclosures. The evidence for the development, implementation, and impact of surveillance for neuromuscular hip dysplasia in children with CP comes primarily from Sweden and Australia. The evidence is impressive and compelling, resulting in a global need for a change in the standard of care through a paradigm shift. The challenges to implementing hip surveillance for children with CP in the US include the fact that there is no centralized medical system. There's no clear or defined referral pattern. Multiple providers and insurance carriers exist, and there's no centralized record keeping. The US healthcare system is fragmented. It is market-driven, favoring short-term versus long-term interventions. It's primarily reactive as opposed to proactive. Children with CP have limited lobbying ability within this system. So in this setting, when we seek a paradigm shift, how can it happen? Well, classically from above, but as I hope to show you, it can also happen from below. The term paradigm shift was developed by Thomas Kuhn in his analysis of the changes in hard science. Within his approach, the pre-science phase would consist of inconsistent management of hip dysplasia in children with CP. In the normal science phase, the paradigm would be characterized by reactive interventions. This would result in failures due to individual cases and due to the paradigm. Appreciation of this would result in a perceived crisis, which would be where we are at now. This is followed by a revolution in which there is a shift or change to a new paradigm of treatment. Finally, the normal science is redefined, in our case, the practice of hip surveillance for neuromuscular hip dysplasia in children with cerebral palsy. As Kuhn understood this, these paradigm shifts occurred primarily from the top down due to the efforts of scientists and other societal leaders. But what about from the bottom up? This was not considered by Kuhn. Change can occur from the bottom up, and this is called emergence theory. In this setting, larger entities arise from the practices and interactions of smaller entities, and the complex whole emerges from the simple parts. In essence, the larger is greater than the sum of the lesser. Our efforts to implement hip surveillance for children with CP in the state of California have included both top-down and bottom-up approaches. For the top-down approach, we created an organization called the California Cerebral Palsy Hip Alliance. This included 10 fellowship-trained pediatric orthopedic surgeons who care for children with CP in partnership with California Children's Services, or CCS. This organization was created to allow us to approach CCS in an organized fashion. California Children's Services, or CCS, was established in 1927 in response to a polio epidemic. CCS provides diagnostic and treatment services, medical case management, and physical and occupational therapy. Over 180,000 children in the state are covered. This includes most children with cerebral palsy under the age of 21 years. The funding for CCS is a very complex mix of federal, state, and county resources. In California, there are 58 counties with a wide range of populations and variable services between counties. CCS services are delivered through medical therapy units, or MTUs. These are embedded in the schools and are staffed by physical and occupational therapists. In addition, there are physicians affiliated with the MTUs. They are state paneled and are primarily physiatrists and orthopedic surgeons. In 2015, we met with the CCS leadership to propose a partnership between the Hip Alliance, consisting of physicians who supported hip surveillance and were committed to proactive management of neuromuscular hip dysplasia, and CCS, who would support hip surveillance and seek to adhere to these guidelines at the level of the MTU. The pitch involved the recognition that hip dysplasia in children with CP is common, it's progressive, and it's best treated early. It was an ideal disease process for surveillance, and surveillance programs had already been developed. Finally, we recognized that surveillance would increase the rate of early surgeries, but decrease the rate of salvage surgeries. The financial impact for CCS would be additional front-end spending, but back-end savings. The presentation went well, and in the end, the CCS leadership said yes. What did this mean? The leadership created what is called a numbered letter, which established hip surveillance for children with CP as the standard of care statewide. The implementation of this mandate included funding for clinical services, but did not include funding for program rollout, development, or rollout. This was, in essence, a partially unfunded mandate. With this achieved, we worked through local empowerment by education and outreach, and this is an ongoing effort. We've sought to develop partnerships between the MTUs and referral centers. This has required a lot of patience, and progress has been uneven across the state. And finally, we've recognized the need for patient-driven centralized record keeping to really figure out the impact of what we are doing. This has been a very challenging undertaking and remains an act in progress. Progress, though, has been made. At the CP Academy meeting in 2019, there was a poster describing the development of a hip surveillance program called Hip Watch through the Medical Treatment Unit in Orange County, California. What about the implementation, though, of hip surveillance from the bottom up? One of the mechanisms of this is the Hip Screen app, which you'll be hearing more about shortly. COVID has had a significant impact on CCS. The services have been limited. There's been a larger reliance on telehealth. It's not clear how satisfied the individuals are with telehealth or its efficacy, but reliance on telehealth does create some opportunities. CCS has been reopening, though the reopenings have been uneven across the counties, and there appears to be issues with decreased staffing and resources. With respect to hip surveillance, we hope to pick up where we left off and not to be starting over. The vision for this initiative was community-based surveillance through CCS staff and local radiologists. This really has not been achieved throughout the state. The reality is that we continue with regionally based surveillance at local children's medical centers with referrals through CCS therapists, other primary care physicians, and affiliated medical subspecialists. With respect to implementing hip surveillance, we seek a paradigm shift. This involves thinking globally and working through organizations such as the CP Academy, but acting locally. In a top-down fashion, this involves working with political leadership to create partnership between providers in the state of California. These are physicians affiliated with children's hospitals and California Children's Services. Acting locally can also occur from the bottom up. This involves a variety of advocacy and educational approaches. There are a number of tools for this, one of which is the Hip Screen app. The goal of all of this, though, is to empower all potential advocates for children with cerebral palsy. Thank you.